Hello, today we're going to talk about Etomidate, otherwise known as Amidate. This presentation is a culmination project for pharmacology in the United States Army Graduate Program in Anesthesia Nursing. Typical concentration is 2 milligrams per milliliter for IV injection. Etomidate's mechanism of action involves the GABA receptors which mediate sedation. This inhibition occurs at GABA receptors that contain beta-2 and beta-3 subunits. Etomidate allosterically modulates the GABA receptor, allowing hyperpolarization. Now watch in this graphic representation as Etomidate in the top left corner moves down, binds to the GABA receptor, causing chloride to influx in, causing a sedative effect. Etomidate is an induction agent and is usually used by the provider once the patient is in the room with baseline vitals and usually right before or after a dose of an opioid, but before giving a paralytic agent. Induction dose IV is 0.2 milligrams per kilogram to 0.4 milligrams per kilogram, with a usual dose of 0.3 milligrams per kilogram. For older adults, dosages should be reduced to 0.15 to 0.2 milligrams per kilogram. Onset of action is 30 to 60 seconds. Peak effect is 1 minute. The T-half alpha of Etomidate is 1 to 3 minutes. So that is how long it takes half of the drug to redistribute throughout the body. So in essence, the longer it takes, the less lipid soluble the drug is. The T-half beta is the elimination half-life, and for Etomidate, it is 12 to 29 minutes. This means that it is how long it takes half of the drug to be eliminated from the body. Etomidate is roughly 75% bound to serum albumin. It is primarily metabolized in the liver and plasma, with only 2% excreted unchanged in the urine. Metabolic clearance depends more on cardiac output than enzyme function. Anesthetic indications. The primary market share for Etomidate is in hemodynamically compromised patients because unlike other induction agents such as propofol, it causes a modest reduction in blood pressure of only roughly 2% on average. For anesthetic contraindications and concerns, there are a couple of concerns with Etomidate, one of which is adrenocortical suppression related to 11-beta hydroxylase and cortisol synthesis inhibition. Another concern is the high propensity for post-operative nausea and vomiting. The provider should be aware that upon induction, myoclonus has been known to occur. Also, the formulation of Etomidate in the vial often contains propylene glycol, which can cause burning at the site of injection. 3 articles for your viewing pleasure are a comparative study of brain protection effect between thiopental and Etomidate using bispectral index during temporary arterial occlusion, and another is propofol and Etomidate are safe for deep sedation in the emergency department. And finally, should Etomidate be the induction agent of choice for rapid sequence intubation in the emergency department? The references are Evers, Katzung, and Morgan and McHale. Thanks for listening, and I hope you have a great day.